So the things that we traditionally think of as like women-centered cancer risk actually affects men too.
What are you excited about moving forward in your field with precision medicine, collaborating with other doctors that want to get in on these tests now or down the line? What are you excited about in your field? Super beyond excited today to talk to Dr. Kana here about genetics and the evolution of her medical career. Genetics is a hot topic right now. There's so much out there, and we're going to get into what is available today for everybody and what is coming out and what she sees happening in the field. We'll get some background on her, and I couldn't be more excited to have her on the podcast. Cool. All right, so let's jump right to it.
Well, thanks so much for having me today. I'm super excited about this because I love talking about the stuff that I love. So,
yeah, and even in the conversation we were having up to this, I was like, I stopped asking you questions because I could see that you like what you do, and you have a really interesting dynamic of how you put your specialty to use. But before we get to all that interesting stuff, I'd love to understand what made you think, I want to be a physician, and then kind of bring me from there to what you studied and what made you go into genetics and kind of where we're at today.
Yeah, it's a great story, and I say that because I lived it, but I always wanted to be a physician. That's since I was little. It was one of those things where you're like 5 years old and you want to be a doctor. And as I was going through that journey and I was in college, I decided, well, I do want to go to medical school, but I don't want to go to medical school in like a farm, which is usually where people end up going to medical school in America. So I applied to one med school because I graduated college early, and it was off cycle, and it was a Caribbean school. Normally people go to Caribbean schools as like their last choice after they have not gotten into a US med school, but I was like, I'm gonna go to one place, and it's an island for, for med school. And
what island was that on?
Grenada. So
Nice.
My parents are not doctors, and they were totally on board because they didn't know what that meant. And so I applied to this school, St. George University. And I got into their Global Scholars Program. So actually my first year of medical school was in England. It was in Newcastle, which is a top 10 party city. And I don't know if you've been there. But
I've been to England, but I don't think I've been to the top 10 party city side. But
people
anyways.
wear Halloween costumes every weekend. And it is phenomenal. The first weekend I saw, Buzz Lightyear and Woody making out in an alleyway, and it was interesting. And so I did my first year there. I did my second year in Grenada. And then I moved back to the States to do rotations kind of all over, had some global medical exposure, Thailand, India, Africa, and then here we are. I did residency in Louisiana in pediatrics, and then I decided I wanted
Where in Louisiana?
Shreveport.
There's a show in Shreveport. Do you know which one I'm talking about?
The vampire one. Yeah. Yes, and that, but I won't go back. It was not my favorite. But while I was there, we saw a lot of genetic cases, and that is what really sparked my interest in genetics. And then I applied to do a genetics fellowship. And I did that in New York City, and I grew up in Connecticut, so it was like coming home for me, and loved that. And then I moved to Miami for, my first job out of fellowship, and it's been amazing. I love it.
So I'm curious now about the first thing you said about knowing you always wanted to be a doctor. What did that look like as like a kid and into your adolescence? Like what made you know that? Like what drew that curiosity?
Yeah, I don't even know, because no one in my family is in medicine. They're all in business. I think I just didn't want to go into business. I was like, I don't want to do this. I don't want to own businesses at the time. And I said, I want to go into medicine. And it was different. And so I think that's what drove the interest. And then I loved science, and that kind of sparked that further. And then I was always really interested in the science classes that I was taking. And so that just kind of carried on through. And it has been, I mean, I don't regret the decision at all. So.
Okay, so you get a job. Well, you do your genetics fellowship.
Yeah.
Which is so cool. And we'll get a little into that now. And you come down here to terrible sunny Miami. That the winters is just so terrible. Don't come here anymore, people, please. It's too busy.
But came here before COVID, so we were not the followers.
So you're you're Miamian now. Yeah. You're not a transplant, so that's good. So the migration, the great migration. You get a job at a hospital that's known for seeing a particular type of patient, and we're talking a little bit about this. And so I asked you, are you focused on that age group or kind of different age groups? So you get brought into this hospital to kind of do what from a genetics standpoint?
Yeah, so genetics is actually, before moving here, I was considering taking a job in Dubai at a children's hospital in Dubai. And so they had recruited me out there, and then so it was either Miami or Dubai, and ended up in Miami.
Those are two great choices.
But yeah, it was a tough choice, but I think I made a really good decision. But here, and I can tell you, it's a children's hospital, and they had hired me to just expand the department. Now, there aren't a lot of geneticists around, and so this is one of those physician specialties where pretty much everyone's looking for a geneticist, and so it wasn't hard to justify the need. And so that was where it started, and then we've been expanding ever since, and our patient base is everyone. I mean, it's not just pediatric patients. I see adults. I love seeing adults. I love doing prenatal counseling, and sometimes we have pregnant patients who have issues with their fetuses, or a family history of something, and they may not have a genetic condition themselves. We see a lot of cancer patients, and so it truly is different. I mean, this is one of those specialties where if you don't want to know a whole lot about one thing, you can know a little bit about everything. And so it's really good for people that just can't do the same thing every day.
Yeah, it feels like it sounds like you have so many different problems to solve. And those problems seem to be changing as the evolution of genetics changes as well, and we get more information back. Yes. Am I thinking about that correctly?
100%. I think when I started this and I wanted to go into genetics, my mentors, and this was a long time ago, they were like, why would you want to do that? It's boring. And at the time it was boring. You would just learn about a condition. You couldn't really test for a lot of them. Now we can test for a lot of things. We have treatments. We've got medications, therapies that can significantly alter the natural history or course of the condition, which is really cool. And so just the evolution of medicine to incorporate genetics and all the therapeutics that are coming from that. And I love fringe science. And so to me, I think it's the greatest thing.
So I have to tell you, before you, I did not know there was MDs in this world. To me, it's all PhDs. Everybody that I've spoken to in the genetic world is a PhD or a master's. So I was very surprised to see that. So can you give me a little, for just for giggles here, a little differentiation? Because I mean that has a lot of impact, seeing it from a medical side and not just, and there's plenty of value on the PhD side, but I want to hear it from you though, because I think that's interesting.
Yeah, so MDs, DOs, from a clinical side of genetics, you see patients who have anything that deviates from expected growth, expected development. And on the PhD side, you're not seeing the patients. You're kind of just working on the theoretical aspect of it. You're doing the research, you're in the lab. And so some people do combined MD PhDs, and so they do both, and which is a lot of school.
It's a lot of school.
Definitely wouldn't do that, but it gives a different perspective as well. And so it is really nice to have geneticists with a PhD background working with geneticists with a clinical background to be able to kind of be a one-stop shop. I mean, they will run a lab, which is not patient-facing, and hospitals that have genetics labs, that's the utility of PhDs in those labs.
Does your team work with any PhDs, or are you MD focused?
Right now, we are clinical MD focused. We
Okay.
don't have a genetics lab in our hospital. We used to, but that's a sore subject. A lot of hospitals that are major academic centers with large genetics practices do have a genetics lab and will have some sort of PhD who specializes in genetics, usually in the background.
When you were going into this, that was okay. So like in the 2000s, we started decoding the genetic code, the Da Vinci Code.
Great book, by the way.
Great book, by the way. Totally irrelevant, but it popped up. And so that was an exciting time. And obviously things are moving a little faster. Can you tell me some advances that have been happening lately that maybe not the average person or maybe even the average physician knows? Because most physicians are in a non-concierge clinical kind of practice, and they're just trying to keep up with the times. So I'd love to hear how some of the advances in the last few years are going and some of the things that excite you and interest you from your job.
Yeah, we used to, and by we, I mean just the collective we, geneticists in general, used to just make clinical diagnoses of common conditions. For example, Down syndrome used to be something where you'd look at a child and say you have the features that look like Down syndrome, so we're giving you that diagnosis. That was decades ago, and then we started to have genetic testing that supported that, and that was like some of the earliest testing was looking for these big differences in the DNA. And then as time went on and testing got better, we were able to pick up smaller differences in the DNA. And really it started out primarily with what we call inborn errors of metabolism. We have the newborn screening that every baby in a US hospital gets done, where they take the blood from the bottom of the foot and they're looking for evidence of conditions that affect a baby from day one of life, and usually need some sort of dietary modification to be able to prolong life and also reduce the complications associated with not treating that condition and to decrease the chances of them just living a more difficult life. So that I think is really cool. I mean, we've definitely changed the course of a lot of conditions because of that. And we've been able to implement treatments, different formulas, supplements right from the beginning that really enhances quality of life for a lot of these kids. And so that is, I would say, something major. Those panels are expanding all the time. They're different by state. And then we're doing a lot of now expanded carrier screening. So where a couple wants to have a child and they find out that maybe they have a mutation in a gene that's associated with the same condition, and then they have a high chance of having a child with that condition, but it's not something they would have known about. And then they would have found out the hard way when they had a child with that condition. And so it kind of avoids that devastation as well if they know beforehand. And then they could do testing if they choose to or would know the risk.
So you have the testing beforehand. You're going to take 2 adults, right? You have the testing, the baby's born foot. I do know there's a testing as you are conceiving a baby too, correct? So I think, and that's kind of similar to. So now we have the 2 parents. We know the risk factors, and now you can
test. So really sci-fi, I would say, or one of the most sci-fi things. We're testing embryos for mutations that we know parents have. And so if we know that both parents are carriers for the same genetic condition because they have a mutation in their DNA, then we can test that embryo most of the time for whatever that mutation is, or those 2 mutations are, to know which ones are affected before they're implanted. And so if you've got a handful of embryos, you'll know whether any of them are not affected, and you could preferentially choose to implant those or not, but at least the risk then is something that you know prior to making that decision. You could also do testing. You can get pregnant naturally, and we do genetic testing during pregnancy as well. The core aneuploidy sampling and the amniocentesis are both needles in the belly at different times in the pregnancy, and those can look for known genetic conditions or even just do general genetic testing if there's some kind of abnormality during the pregnancy on ultrasound or in other screening tests.
So cool. So cool. A little scary too. That was very cool. All right. So that's some of the stuff from preconception to conception. And you're already getting some data points. So that's very cool. Now we get, out of that baby stage and we're getting a little bit older. So what changes with what you do after, that initial phase of being born from the baby? What's the next kind of category of testing that you do a lot of or not? Like where do you go there?
Yeah, so in childhood, great question. So, we have, once a baby's born, if we don't know that that they're going to be at increased risk of anything, but then we see that they end up in a genetics clinic, it's usually because they have an abnormality to their appearance. There's something unique to the way that they look or their growth. Or they're not developing the way that they should. They're developing slowly. They have a difference in their muscle tone. They may not be eating very well, or they may have poor weight gain or excessive weight gain. And so when we start to evaluate individuals after they're born, we're using their phenotypic information. So physically, what are the things we're observing that are not considered to be typical? And then we can do genetic testing based on whatever those things might be, especially if it's affecting multiple organs. And then we know maybe there's an underlying cause. It's kind of like a constellation in the sky. We're getting all those different points to see if there's an overarching explanation for why that is.
And then you come up with a treatment plan and help that kid adolescent with their family group.
There may not be treatments. I would say most genetic conditions right now don't have treatments, but a lot of times it's just information. Like if we make a genetic diagnosis for a child, we may know that this is associated with an increased risk for a learning disability, and then that family knows how to plan school as they get older, or if there's an increased risk for seizures or an organ system that's affected that they don't know about, then they know to look for that. And so it's not a surprise if it comes up later.
So this, and if I'm jumping too far ahead, we can always go backwards. So you can just bookmark me there. So this is a part of medicine I find absolutely fascinating. And you said it in a different way, more towards the child, but like if you have a genetic roadmap or a snapshot of what my risks are, we're not going to go into anything too scary for me. I get like that I get a little weirded out by that. But anyways, but I think as a patient, as a consumer, and you're thinking about your health and you're thinking about your longevity, you have an option now from someone like you that's looking at these things and understands to take a snapshot or what are my risk factors. And I have to be super thankful to some of these speakers out there and these MDs that are talking about these kind of things, about preventative medicine, which is where we should be in this country and what we should be thinking about investing in. Everybody's buying shoes and purses and this. Get a good doctor. Get a geneticist on board with that good doctor, and take care of yourself. So you can buy more shoes and purses if that's what makes you happy. But you can get these snapshots and look at these pillars of health that you can potentially have enough data information so you know where to go. Now we do that. We do whole genome sequencing and we do certain panels, and we were talking a little bit offline about those. And that allows us to set people up with certain specialists and things of that nature, understand the family dynamic, or if they're about to have kids, or if their kids want to have kids, what the risk factors are. So I am familiar with what you do. I just I want to bring all this out on camera. Oh. And so, but I do find that like for me and people that are starting to think about on the back part of their lives or high producers, I think about what kind of information should I be thinking about and what kind of risk factors, and so and how we can kind of think about treating those or optimizing for those or avoiding those. So I'd love to hear how you think about that for your adult patients, because although you work with a children's hospital, you also told me you see some adults.
I do.
You see a lot of adults, I should say. So I'd love to hear more of like from your insights what you think about that instead of just mine.
Yeah, well, I think, and that is where medicine is headed, precision medicine, personalized medicine, especially in the genetic space. We are just not completely there yet. I think polygenic risk scores are the next big frontier in medicine. I mean, that's going to make things really easily digestible and relevant to people who are seemingly healthy, that don't really think that they have a whole lot going on that's enough for them to come see a geneticist. They don't have any major developmental concerns, any major medical issues that seem atypical for just, whatever it is that may be related to them, aging or family history or things like that. So, I think, and this is so exciting to me, but polygenic risk scores are what you're talking about, where we're saying, well, you have a healthy adult. What is your risk for, let's say, dementia? It's going to be, once we figure out how to interpret this information usefully, then we're able to tell you, well, you might be at a 4 times higher risk than the general population of developing it because of these changes. And maybe these are the lifestyle changes that you may want to make to try and mitigate that risk. And so we have some of that information for some psychiatric conditions. We know based on polygenic risk scores, maybe what your odds ratio or your risk might be of having something like schizophrenia, depending on how many people in your family have it. And so that is where genetics is headed for, I would call it the general population, which is super exciting. And then also with epigenetics and methylation, we are able to come up with these, I would say, actionable findings eventually. I don't think that any of that information right now is very useful, just due to us not knowing enough about our DNA. I would say at the most comprehensive, we know about what less than 10% of our DNA does. When we do whole genome sequencing, even from a clinical perspective, we're sequencing theoretically 100% of the DNA, but we only understand like less than 10% of what that means. So
kind of sounds like what we know about the brain.
It's true. I think we know more about space and the oceans than we know about our own DNA. And so
it's crazy.
And the recreational testing is just like, don't even get me started on that. But
define recreational testing. Go ahead. Recreational testing.
The recreational genetic testing, we just don't know that those results are reproducible. Those labs don't always have the same certifications that diagnostic testing labs need to go through to be able to prove that all of their findings are legitimate and factual. And so some of the tests may have undergone that same sort of certification that's very rigorous for diagnostic labs, but not all of their tests do. And so a lot of this information we take with a grain of salt, I would say, when it's brought to a clinical genetics practice, and then, we don't really know how to interpret it yet.
It's interesting. I had to avoid getting into an online conflict yesterday. And it was around that, though. And so the things that you get in mail direct to the consumer don't go through the same rigorous things that your physician has to get for you. And there's a different level that needs to be passed for an MD to give you something versus you going online and buying from a shop. So it's interesting. There's some things that are super fun. Don't get me wrong.
Yeah.
Where you're from, that's fine. Like whatever. But from a health perspective, I think we're not utilizing the professionals that have the clinical acumen and have the highest standards of tests. I can't get anything by you on the genetics side. And you're kind of potentially going down the wrong road and listening to the wrong people, most of the times without an MD or PhD behind their names. And I think it could be okay because you might be fine, but it could be a slippery slope as well.
I think so.
Yeah. So, and that's really interesting. So I think, I was just literally having this conversation recently, and not all primary care and specialists have time to go through this. But if you do get to a certain point that they might bring someone on like you or run a genetic panel, whether it's, the 3 ones I think of when you back out of whole genome sequencing. What I like about whole genome sequencing is every company that I talk to, I ask, do you constantly update me when something changes with, the American Board of Genetics and Medicine, whatever it is. Like, I forgot what the acronym is. And I'm like, do you constantly update this, right? So if a patient does this today because we don't have all the DNA sequence, but it changes 6 months from now, are you going to tell me? Or do I pay for that? And that's okay too, because hopefully every year, and we're seeing a faster progression, it seems, with technology and the ability to test these things faster. that's the one question. But then when you back out of that 10%, there's a couple panels that I think I've seen from our side that patients are very interested in. Mm-hmm. You went over one of them, and that's like the dementia one and the psychiatry one, which some people in the population don't want to deal with that, and some people do. You know, some people just rather not know. Mm-hmm. And actually, when they do some of the whole genomic sequencing that we offer, and some of the clients and people that I know offer as well, you can actually opt out of that part.
Yeah.
And to unopt out of that is like a legal battle. It's pretty cool. It's interesting though, right? Like you have to get like a lawyer, and all these things to reverse that. But there's three things I think of, two other things besides that one. And there's a cardiovascular panel that seems to be, you know, pretty popular. And then one around cancer. Mm-hmm. And we're talking a little bit about that one before camera. So, I mean, I would love to know your thoughts on it and kind of how that can kind of shape someone's snapshot looking at their longevity and stuff like that, and what you think from your clinical perspective and your expertise.
Yeah, you know, and I think all of these panels, when we're asymptomatic, I would take it with a grain of salt, because, you know, you could find that you are at increased risk for, let's say, stroke compared to the general population by 4 times, but then what are you doing in your lifestyle? And also, how are the other 2 billion letters in the DNA communicating with that one, right? And that's what we don't know. And so taking this information and using it in a preventative manner is, I mean, that is to be continued. I think that is the point. But right now it does a decent job of saying, well, I've had a stroke and then I had this testing and now I know that I'm at increased risk. So maybe this is contributing to why. And so genetics right now, genetic testing, even the one that's meant to be used as preventative testing or just population health-based testing, is still pretty bad in doing that, but it is helpful in trying to explain why something may have already happened. Just like with a cancer risk test, if we test a healthy individual who's never had a personal history of cancer, and we find that they have a risk mutation that puts them at an increased risk for cancer, it doesn't mean it's ever going to happen. It just means that maybe you shouldn't be smoking, or maybe you should use sunscreen, or do those healthy lifestyle modifications and recommendations that someone would tell you to do anyway. And so if you had a personal history of cancer and then you went back to look at this same information, you look at it in a different light, and then you may want to make other considerations, like, should I be screening for cancer in other organ systems that I haven't had cancer in yet? And what is my risk of that happening? How do I screen for that? You know, and the same healthy lifestyle would apply, but that would give a treating oncologist sometimes a roadmap in, well, let's not use this type of medication, chemotherapy, radiation might make things worse, or let's change our game plan. So that's the relevance of that sort of testing, just in a clinical manner, in people who are affected already.
I think that's interesting to hear that from you. Like, I think that's interesting. But so I think of this, what if gosh, I hate saying mine, but I'm going to. What if so I'm a pretty healthy individual. I do really well across a scoreboard, and there's a lot of people like this, and I hear it all the time, and it usually ends up being the heart, but healthy individual across most of the board from VO2 max on, okay, DEXA, you name it, doing fine. But I do have a family history of some cardiovascular stuff, right? So, which is wild, because I eat pretty well and all these things. So let's just utilize what you said, the 4x risk of stroke. Let's say someone healthy has that 4x risk of stroke, but they're not seeing a physician all the time, which is the vast majority of the population.
Right.
Because most people just look at going to the doctor as not fun. I don't want to wait for 3 hours. I don't want to deal with this, and just tell me what my blood work is, and that's fine. But if you go to someone that is able to look at your lifestyle medicine and look at it from different perspectives, and let's just say you end up doing that genetic panel for the cardiovascular, understand that I have a 4x risk for this, even though I haven't had it in my family. And then they're looking, and maybe your blood pressure goes up. Now you do another test, a couple other tests from CT, calcium scores and that. We see a couple things. Now the doctor has some snapshot to just keep it in their mind as your treatment algorithm, although we don't know exactly if that's going to happen or not. But I think where people are starting to get interested, and I think this is why people are going outside and doing their own things in the delivery boxes, is how do I avoid that thing that can take me out? How do I do that? How do I live that healthy lifestyle if I'm not? Or maybe that's an opportunity for the physician to say, listen, you're living a very poor lifestyle, and although we don't know if it's going to happen, you have a higher risk.
Yeah, I think it really helps facilitate those conversations for people who are already not living an optimal lifestyle. Like if you are living this very optimized lifestyle and you have a family history of something, but not you personally, and those family members may not have been living as optimized a lifestyle as you, is it going to make a difference for you? Probably not. But if you are drinking, if you're smoking, if you're high blood pressure, you have these things going on that are going to increase the risk. These are environmental contributors to that risk. Then maybe that conversation with the physician or whoever does that testing is enough to make you stop or reconsider those changes. I would hope so too. But
come on, patients. We all know I'm a bad patient sometimes, and sometimes I'm not. Depends what it is.
So if it changes at least the thought process for some people, I think it does its job. But then we're looking at, this is I feel like a whole other podcast episode, but
we can do another one. It's fine.
Then we're looking at, how much prevention ends up being too much in terms of overanalyzing, overdoing, the prenatal MRIs, these preventative MRIs, how many of them find incidental findings which then lead to anxiety, which lead to unnecessary evaluations and multiple unnecessary evaluations that then end up being nothing. And how many people actually find legitimate things?
And so that's the argument out there. And so I can tell you, people ask us, not me personally, but ask the physicians at Pure for that scan. And I think there's something interesting there if you're living a great life. And I'm like, let me just clear this. And people want to pay for it. People come asking for it. We don't even have to mention it anymore. It's becoming so popular. Thanks, Kim Kardashian. Why did they hire Kim Kardashian for that? Whatever. I don't care, Kim. So it's interesting, right? Because some of these people have access to everything, and they don't care about the insurance. They don't care about the costs. And they're like, give me everything so I know as much or as even that little part of data that I want to know. They do it that way. And that's why it's not accessible to everybody. And I also see this split in medicine going now, where if you have the capital and the means, you get to spend time with your doctor, you get to look at your preventative health and your wellness and what you're doing for lifestyle and come up with a plan. Or you can't see a doctor for 3-4 weeks, which is the norm, right? And so I'm a big fan of concierge medicine, and even I think there's a place for direct primary care too. Because it allows patients to talk to the doctor. So that's a thing though, right? Do you ignore it or not? Do you wait till if you're symptomatic or you have a symptom, right? I personally have had 2 friends that, almost like the Marvel movie with Thanos, got diagnosed after going to a hospital, and it was game over for them.
Yeah.
And I don't know if it would have been because it was brain cancer. So what they had was very difficult to get out of, but where's the answer there? And I see both sides of it.
Exactly.
But I have
do too.
Unlimited capital, and I want to make sure I'm making sure there's no speed bumps on the way to the end of my life. I mean, why not spend that? And I also understand the medical system can't handle all these things, because right now doctors can't handle everybody being cleared for whether it's Prenovo or any of these other wonderful, interesting, wonderful, potentially wonderful if you like them or if you don't, tests that are out there, because it would overwhelm the physicians because there's too many things, and we're still just getting out of the starter's block with this information.
Yeah. I think technology is rapidly evolving, and we have these things available to us. And now we have, this is the age of over-information. We've got a lot of things that we have access to. I have, and this is all doctors, I think, are facing this a little bit of an issue where We have patients who have access to test results before they know what they mean. And, and Google is not our friend. It's just not always.
You have to get this cup. Dr. Miranda has it downstairs. It's something like tell me where you got your Google medical degree or something. It's her coffee mug. It's fantastic. I'll send you a picture of it. I'm totally hacking it right now.
And it could be a whole lot of nothing, but then Google tells you you're dying. And
every time, by the way,
exactly.
Every time you have the worst thing.
You have a cough and it's lung cancer, and so I think that we are in this like gray area of how much is too much and how much is legitimate. Like what is good enough? And so, and I think there's arguments to both sides. And if you do something preventative, like a scan, and you find something and it's something that you can just take care of and it's done, I mean, of course, that's amazing and you love that. But if you find something and it's nothing and you go through a year of trying to figure out that it's nothing and all of the anxiety and the mental toll that takes, you might have come out of that saying, well, it wasn't worth it. And so, so I think that there are arguments to both sides. And at the end of the day, it's like that person knows what they can handle mentally. And that I think is like one of the most important things to take into consideration.
That is so important. It comes back to what we were talking about, like the dementia, genetics and all that. That has to be a very solid conversation with your provider. I know of someone, and unfortunately, whatever, it doesn't matter who it is, but they did not explain that. And that the staff and the other physicians affiliated with this group had to take the back end of this, and it was not explained well to the patient, that part. It's like, hey, look, are you sure you want to know these things and all this? And what ended up happening is that provider left somewhere else, and then that person had a very difficult time for years and finally came out of it. So I've seen that side too, and I'm like, oh man, that stinks. But that's a very intimate conversation you need to know and be aware with what you can handle, and that has to be an intimate conversation with the provider that you're speaking to. Because if you can't handle that and the tests that come down the line, then maybe that's better for you not to know, right?
Well, and also that brings up a really good point, counseling. I mean, I would say non-geneticists, geneticists are trained to counsel, genetic counselors are trained to counsel. They're trained to give all of the information, and it is exhausting and a lot, but these conversations are very, very detailed prior to initiating testing. To go over what we might find, what we don't find, what negative test results really mean. And so non-geneticists and people that are not in the genetic space that order these tests regularly, they don't counsel. And so when we get these results back and, they'll end up in a genetics clinic or with a genetic counselor, and they're like, what do these results mean? And sometimes they get back and test like exome sequencing and genome sequencing. They have a secondary findings option, and that reports out stuff that has nothing to do with the symptoms that you have necessarily. But these things can be just life-altering to know about, like increased cancer risk and, increased risk for things that could happen to your heart, for example. And not only is that anxiety inducing for you to know about it because you didn't know you were going to find out those things unrelated to your symptoms, but now life insurance and disability insurance knows about those things too. And
do your life insurance before this, people.
And so, life insurance and disability, if you don't have those in place, they're going to ask about them, and they may price you differently or deny you completely. And so that is, and people don't think about those things.
That is a great point too. Like, you need to have your life in order before you go down this rabbit hole, because they're also looking at you as a risk.
Exactly.
So you're looking at your genetic risk, and they're looking at you as a risk, as a client, as a patient of their insurance group. So that's really interesting. I found like there's some tests that are available to physicians that have a plethora of VULs on them and stuff. And I think it's a little muddy there, in my personal opinion. But I'd like to hear from the MD your opinion on those. And so that's a conversation I've had with several physicians. Is like, okay, do we should put these aside until they become more prominent or more well understood.
So I don't agree with that. And that's why I feel like people who order genetic testing really need to know what these results mean. Because, I'll give you an example without giving identifiers, but I had a patient who had some variants of uncertain significance on testing that they had done for, an unrelated reason.
VUS or VUL?
VUS.
Oh my God, what was I thinking about? Oh, sorry. Go ahead. VUS. Anyway, I'm sorry.
But she had this test done, and it showed that she had a genetic condition that is responsive to treatment, to medication that helps prevent it from getting worse.
Okay.
And these results, this test was ordered by a non-geneticist, and these results kind of sat with her for 2 years, and they were actionable. And so, her delaying treatment by 2 years significantly impacts quality of life and length of life in the case of this condition that she ended up ultimately being diagnosed with after coming to see me in my clinic. And that's because you can tease out what some of these VUSs mean.
Okay.
And that sometimes there's biochemical testing. There's testing looking not at the DNA, but at the enzyme products or certain components of the blood or the urine or different tissues that could give you more of a hint as to whether these changes are relevant or not. And so it really doesn't do them any justice if these test results just kind of get put off to the side for reanalysis to happen. In some cases, that is all we have, but not in all cases.
So there are some VUSs that could give you some clinical information that would be helpful for like a preventative nature or getting ahead of the curve. Okay.
And because you can tease out what some VUSs mean just based on follow-up testing sometimes. And it could be as simple as testing other family members to see how they're being inherited. Are they coming from a healthy parent? Are they coming from no parent? Is it that it happens spontaneously and we don't detect it in mother or father? Is it that a child who's affected and their parent who's affected has the same variant of uncertain significance, and we can draw conclusions possibly based on that? So, there are definitely other things that can be done for those differences, and it's just a matter of sending them to the right people to get those things done.
Now, your answer, would that be equivalent to someone that's a genetic counselor, do you think? Or
so they don't order follow-up testing.
I think that's where we're falling very short.
Yes.
And maybe this is why I don't have the understanding. And then again, I'm not clinical, so it doesn't matter what I think. But it's for me, I'm a consumer. I'm a pretty well-educated consumer in your world. So now even that, I'm like, my light bulbs are going off left and right here.
Yeah.
Like how interesting. And so I am setting you up for this question. Go ahead. So
I'm for it. I know you're going to ask, but go ahead.
But anyway, so a lot of these testing companies will provide a genetic counselor, not a PhD and definitely not an MD. So I don't think there's any follow-up. So it feels like it just stops there. It's like, this could happen. Let's see what happens, right?
Yeah, it does.
And so you're giving a completely different angle on that. I think that a lot of testing companies should hire her. If you can afford her. Yeah. You better pay her well. And I want a portion of the findings here. So, I mean, go ahead. You were saying that the follow-up tests and stuff that you can extrapolate from the VUSs.
Yeah. So a lot of these companies won't report them out, or it won't report out the important ones anyway, because then they could be held liable for not following them up. And so companies that are recreational in nature just will either report out definitive, known pathogenic mutations, things that we know are going to cause an increased risk for something, or they'll report it out and call it negative with the disclaimer that they're not going to report out variants of uncertain significance because they don't know what to do with them, and they're not going to be the ones telling you what to do with them or how to do follow-up testing. And so some reports won't even mention those, but for the ones that do, and then that conversation is how did the genetic counselor, it probably ends with go see a geneticist, which is leaving it open, I would say. And
no, it's fine. You said unsignificance? Well, I'm good. I'm good, and go right back to work.
Not the best approach, but and so we see this a lot with just commercial companies and recreational testing. diagnostic companies usually need a physician to order it, and so they expect that liability to fall on the physician when they get the report back, and then it's up to the physician to say, oh, maybe if I don't know what to do with this, I should send this to someone who does, and sometimes that doesn't happen, and so there is room for improvement in that chain, I would say.
Yeah, I'm already excited, already thinking about our collaborations moving forward, so... And that's good information too for people to know, because I think if you do get a physician to write that for you, if you just have a regular insurance taking primary care physician, most likely they're not going to get details with you if you can get them to do this for you. Probably most of them would say no anyways. And then when we're getting into the precision medicine field, that's more towards a concierge medical doctor. And so they're also trying to look at this too and do what's best by the patient. But I still believe, although the concierge physician probably handles the vast majority of problems, it's always a team effort. And having a great team in place is ultra important to make sure that the patient has the best outcomes or the best preventative outcomes as well. 100%. So that's, wow, I'm already like overwhelmed here with wonderful information. But I now I'm getting to the next part, because now I'm curious. So what's so exciting in your field moving forward? You gave us a little tease earlier, but like, what are you excited about moving forward in your field with precision medicine, collaborating with other doctors that want to get in on these tests now or down the line? What are you excited about in your field?
Yeah, I think genetic testing, endless possibilities. Like, everyone can get testing for a good reason. It's just figuring out what that sort of testing is. Every population can get tested. I mean, anywhere from prenatal to just live humans, postmortem. Like, there's just so many populations that benefit from genetic testing, or all of them. Global reach as well. Like, genetic testing in the US is decent compared to other countries, but there are countries who are just not really doing it as readily as we are. Therapeutics, I think, is super exciting. We have therapeutics now that significantly alter the natural history of diseases that, ordinarily are just devastating and degenerative, and you see like early childhood death, and now we're able to prolong life in some kind of meaningful way. And so the clinical trial space is really exciting, and the pharmacogenomic space. And so I went into genetics also because I love fringe science, and this is the most fringe of science, I think. And so it really is so exciting to me.
It's going to continue to evolve and change. So you're always going to have something new to look at and something exciting to take a peek at. I forgot to mention something, because as usual, I got into a deep conversation, but I'm glad I remembered right now. So we were talking about a couple of off panels. And so one of the more popular test ones and for genetics is like, the BRCAs and more towards, although I understand the males too, but for the primarily females for, the ovarian cancers and et cetera. And I mean, those are pretty invasive procedures. So where are we there? Are we pretty well understood there? And what are your thoughts on those?
I think, and I'm going to try and understand your question, but I think that, when it comes to genetic testing for like cancer risk.
Yeah, for breast cancer, ovarian cancer.
So the things that we traditionally think of as like women-centered cancer risk actually affects men too. Mm-hmm. And, and so this is something that is not really sex specific. I mean, we can even see an increased risk for breast cancer in men with BRCA2 mutations, and that's going to be much higher than the general population. And so things that we used to think maybe primarily affected women, that's not always the case. We just don't also know as much about men's health when it comes to things that increase the risk for them dying, because men just don't want to be studied in that way.
We just do stupid things. Have you seen This Is Why Men Die Earlier? It's like the guy is like jumping off a cliff. You're like, what are you doing?
So, so I think that like multi-cancer testing is applicable to both men and women, and definitely has its place in terms of affecting screening long-term, ultrasounds, MRIs, colonoscopies, things like that, other than diet and lifestyle, which I feel like are a given. If anyone in your family has cancer, that should be on your mind. And then just in general, because aging, I feel like cancer is super common nowadays. And so just keeping in mind that diet and lifestyle goes a long way in prevention in and of itself is just important.
What do you think about the food we eat as Americans?
I think most of it's garbage, and so that is a whole other podcast as well. But, I think everything that comes out just with ultra processed foods and dyes and all of those play a role also in just neuroinflammation. And I do believe that our functional integrative medicine friends have a really good grasp on that. It's just adopting it into conventional medicine takes longer because they really are ahead of their time, but we just don't have the evidence to support this being adopted into just everyday conventional medicine use. And that is probably by design. But,
right.
So I think that there is a lot to it for sure.
Yeah, I think there's a way to integrate both. It's
Yes.
kind of like coming back to what we're talking about, medical doctorate in genetics versus over here, right? If we can come together, we're going to have better outcomes. You can spend a good amount of time with patients with your physician?
I get to. Yeah. Genetics is one of those fields where I'm not spending 10 or 15 minutes with a patient. I will spend 30, 45, 60 minutes, maybe sometimes over an hour with each patient. I love that too, is you really get to learn about a family and you really get to learn the ins and outs of how someone's developed. And so that to me is really special.
So you're one of the very few professions that doesn't have to,
Yes,
turn over.
It's kind of like a lesser known secret, well kept secret. I don't know the phrase.
It's like a built-in concierge practice because it has to be. That's good.
It has to, yeah.
So there's other things, optimization things like that. What other things are sparking your interest now, or what do you have going on?
Yeah, I wear a lot of different hats. I do a lot of consulting. One of the things that I do that I love is reinsurance consulting.
Okay.
So, insurance companies have their own insurance companies. They're called insurance companies.
Insurance companies have insurance companies.
It's like Inception. So I do that for a very large global company, and a lot of genetic testing outside of the U.S., mostly in Asia. A lot of insurance claims in Asia, they take into account genetic testing. And so, they price policies based on genetic testing results and also family history and what they think the risk might be for someone to live a shorter life or have some sort of complications related to whatever that might be. So that is very cool. Also, I've got a couple of different things on the side, but one of the things I'm doing is I started a supplement brand as well, which is so exciting.
Okay, tell me more.
And so in genetics, we do something called metabolism, and metabolism is where individuals have issues with the way they metabolize, like they physically do not have the component used to break down a food that they eat, a protein, a fat, a carb, whatever it may be. And so we treat these patients or manage them with dietary changes and often supplements. And we want supplements that work. And so we know, we learned just very early on in genetics that gummy supplements are garbage. They don't work, and so...
It tastes so good.
I know. So my rule of thumb is if it tastes good, it's probably not working. Oh. So, liquids...
Just lie to me, doctor. Yeah. Just lie to me.
So, so we've been surrounded by geneticists have been surrounded by knowing that supplements need to work for you to use them. And we're in the era of everyone taking a supplement for everything. And so... during COVID, I got very into matcha. This is bear with me. And
there's a lot of people that got into matcha.
How this is going. So I love matcha, and it's something that, we had a lot of time to whisk it and to make it properly. And I feel like it was kind of a ritual, and it was great. And then COVID didn't happen, and then we got busier, and I can't sit there and whisk matcha anymore, and so then it just was hard to make. And I'm like, but I still really like it. And is there a way for me to get it in without having to make it? And so I started on the journey of like, well, maybe I can pop it into a capsule and take it as a supplement. And so in my research in kind of learning how to do this, I learned, well, you can't really just crush up matcha and put it into a pill and take it because it's not bioavailable that way. It has to be steeped, and that's the point of it. And then in doing that research, I found out that most matcha has mold in it and heavy metals. And so unless you're sourcing it from like a really clean farm, you're probably consuming a lot of stuff that you don't want.
Matcha has mold.
Matcha has mold.
It has a ring to it.
And heavy metal. Yeah, I mean, great advertising.
And metals.
Yeah.
Mold, metal, matcha. Mold and metals.
Moldy, metal-y matcha. And so, we started to, my husband and I, during that time, we started to just think about, well, you know what, let's just like find out if we can make a supplement that mimics the effects of matcha. And so in just having this background of supplements that need to work, I was trying to figure out how to do that and came up with just a formulation that initially was just intended for us. I mean, it wasn't going to be something that we're giving to other people, but the minimum order size from the supplement manufacturer was
MOQ, baby.
500 capsules. And we're like, oh my gosh, we're not going to take all of these. So then we start handing them out like candy to the people around us.
Look at that.
We're like, do you want to try it? We have all this, we have all these. And people are like, yeah, sure. And then they started coming back for more. And we were like, oh, maybe this is like working to some way. But then these people started coming back and they're like, I did my taxes. I cleaned my house. I did the laundry. I never do the laundry. And we're like, what is going on? And so it's acting like this mild stimulant. And so
I'm gonna start giving this to a lot of people.
So I went back and I'm looking at the ingredients, which there are not a lot of, but just looking at, and so in metabolism, we play around a lot with amino acids, with just components of proteins, of fats, of carbs, and and one of the ingredients we put in there is spirulina. It's like a really beefed up multivitamin. It's got a great B vitamin profile in there, and it's got some other things. I mean, it's a fantastic. It's almost like matcha, but just better. Like it mimics the supplement and the vitamin and mineral profile of it. Just without matcha.
Without the metal,
the moldy
metal.
Yeah, and so I'm looking at that, and then I put something else in there called L-theanine. And a little bit of caffeine because, I feel like matcha, that probably is one of the things that makes people feel really good. But the caffeine and L-theanine is what is naturally occurring in the matcha. Mm-hmm. And then the spirulina I added because of that vitamin and mineral profile. And inside of the spirulina, there's something called phenylalanine. And this is like me getting really, really geeky because of my genetics background.
You just gave away the formula. We should have left that out.
Well, it's patent pending, and so you can try and do it.
We'll edit it out. Yeah, good luck.
But so then the phenylalanine and the L-theanine, the way they react with each other with the caffeine, it gives it actually like a mild stimulant effect.
You had me at stimulant.
So we are patenting it.
That's wonderful.
And so it's patent pending.
So I love those stories. So some of my favorite business stories are like, I had an itch, I scratched it, gave some away, and people liked it. And I am solving like a little problem. So I have to get some of that from you.
Well, I have one for you. I have it hiding. Oh, here it is.
Okay. Oh,
so
gifts. Oh, I'm so excited.
But, so it is, and you can take it up to like 6 times a day. It's got a little bit of caffeine in it. It's like a cup of coffee. So.
Oh yeah, yep. I definitely, on my bad weeks, I have a lot more caffeine than this.
Yeah, so you can take it, and and so far it's been overwhelmingly positive feedback. I mean,
that's great.
The negative feedback I've had is that it's not doing anything for me from like just a couple people, but I'm like, maybe just you didn't need it to begin with.
Or they're completely overstimulated on 700 milligrams of caffeine a day.
Maybe that's
potentially.
It. So, but I feel like overwhelmingly we've had such a great response. I'm so excited about it.
It's so awesome.
And so that's like supplement number 1 of hopefully a whole line of things that work. And that's, that's the hope, the goal.
And I think this just makes sense with like, how you look at the genetics and stuff. You're curious and you like finding out things and looking at it. You're talking about like your curiosity for science and things. And so I think this works perfectly well with everything you said. So I'm so glad. And I love having ultra educated people bring things that make sense, where it's usually coming back to what we said, people that are doing this. I also heard by the way, side note, I have two things to say today, and I have not had a chance to look into this, that kale is moldy and gross and metally.
Did you know, this is a fun fact, courtesy of my husband who's full of fun facts, is that kale, Pizza Hut was the largest consumer of kale because they would use it to decorate their salad bars.
And then they started this whole kale campaign.
Cool, yeah.
Cool kale campaign.
Yeah.
Oh my gosh, we're gonna get a marketing contract out of this one. I was like, I need to look into this. But I mean, it's unfortunate. More than half the time you look into it and you're like, oh my God, that's true. Yeah. I'm always ordering the kale salad. And now I'm like, oh boy, here we go. Moldy, metally kale.
Yeah, moldy, metally kale.
You said something that triggered something too. There's some athletic genetic, very small panels that I think that was when I originally started looking into genetics a long time ago. I was trying to scratch my own itch and figure out how I process foods and stuff like that. And I have it somewhere locked on my phone somewhere. Like I have this 50-page thing. But what do you, is that kind of what, I wouldn't say maybe from the athletic standpoint, but what kind you were talking about, how the metabolites and and the proteins and stuff?
No. So, metabolic testing or just a metabolic workup is usually, it's called biochemical testing. It's not looking at DNA up front. It first is looking at how you're processing these foods that you're eating to see if there's anything that's building up to a toxic level, meaning that you can't break it down and you should be. And so we use blood, we use urine, usually we try getting fasting samples. And so it's definitely collected and evaluated differently than doing just DNA testing.
And that's not like a food inflammatory or sense, no. Okay.
Yeah.
I'll ask you some more questions about that offline.
Yeah.
So, okay. So, I mean, there's super exciting things coming out in your field. There's super exciting things that you already are coming out with.
You'll have to try it and tell me if it works for you.
Oh, I'm totally taking this. I'm gonna go. I've tried Lion's Mane coffee. It's fine. It's not the best tasting coffee out there.
Yeah, but if you take that and start doing the laundry, then it works.
Oh yeah, absolutely. If I don't reach for my third or fourth coffee, I already know. Even if I went on vacation and I cut my caffeine by a very large amount, and now I'm back up and I'm like, okay, I gotta stop this. Today's one of those days. Did you walk? Yeah, I had a coffee cup when you walked in.
So. Yeah.
I don't like doing coffee after 2. Today I was like, I need a little kick for us.
You should switch to that then.
I'm going to.
That's a good afternoon pick me up.
I'm going to. And you have a website?
Midday slump. So we do have a website.
Okay.
Notbrands.com.
Notbrands.com.
Well, because we were going to call it Not Matcha because it's not matcha, right? But then when we gave it to people and they said, I just feel really focused. I was like, focused is a better name. It just kind of tells you what it does. And so we've kind of expanded our population of people who maybe only like matcha to everyone could use some focus. And so
I think you should still buy Not Matcha. I'm just going to tell you right now, especially because it's moldy and metally.
You can A/B test that. Yeah,
you should. If you don't, I'll buy it and I'll sell it to you. It's fine. I'm not gonna make money, but I don't want anybody else buying it. Don't you dare, Rob. So I really thank you so much for taking time out of your busy life and your family to come by and have this conversation.
Of course. This is great.
I just can't tell you how much I appreciate it. And I love your field. And now I know that everything I think is completely nonsense. And but I think your field is going to have so much impact on all of our lives. And at some point, maybe it's for the cash paying patients today, but there's a bunch of opportunity in your field for the family health and to know what's going on. And then it's only going to get more interesting as we evolve. And with the science behind it and proving the other gazillion DNA pieces.
Oh, it's so
good. And you're never gonna, I feel like every year probably something changes for you. So.
Oh yeah, it's the best. It's absolutely the best field for someone who has a difficult time focusing on
Yeah.
one thing. So it's,
That's probably one of the fastest changing medical fields,
Yeah.
because everything else is still moving slow.
Yes.
And
Or it's done, like cardiology. I mean, what's left? We know everything.
I think maybe just the genetics.
You know,
I mean,
yeah.
that might just be it,
Exactly,
right?
yeah.
So we know the lifestyle, we know everything else. You know, family history is huge. I mean, yeah, you're right. Like there's not, so it's your field that's going to change or give us more information on how we can be healthier. And so, I mean, if you can go out there and get some of the things that she said may or may not help you. If you have a provider that can look at some of these things and try to avoid it, and just know that we're still getting more information, but it's somewhere to start. If that's not something you want to know, please don't do it, and and figure out what's best for you. But super fascinating field, and thank you so much.
So good. Thank you.
Thank you so much.
So good to meet you.
Likewise. Likewise.